Hi, this is Dr. Junaid Kazmi. I am Fellow of Thoracic Radiology and Intervention at All India Institute of Medical Sciences, New Delhi. Today, I will present Journal Club for Society of Chest Imaging and Interventions. In this video, we will talk about reporting incidental coronary, aortic valve, and cardiac calcifications on non-gated thoracic CT. This video is based on a consensus statement from the British Society of Cardiovascular Imaging, British Society of Cardiac CT, and British Society of Thoracic Imaging that was published in British Journal of Radiology in the year 2020. This statement provides guidelines for reporting incidental coronary, aortic, and other cardiac calcifications. These guidelines provide recommendations for reporting of coronary, aortic valve, and other cardiac calcifications identified on non-gated thoracic CT performed for non-cardiac indications. These guidelines provide a reporting framework that is essentially understood by reporters and those who refer the patients. Heart of these guidelines is a simple visual ordinal scoring system for coronary and aortic valve calcifications designed to minimize the time required to implement these guidelines for routine clinical use. Cardiovascular disease is one of the leading causes of death in the Western world, with coronary artery disease accounting for greater than 10% of all deaths in United Kingdom in 2017. As far as Indian scenario is concerned, in 2016, India reported 63% of total deaths due to non-communicable diseases, of which 27% were attributed to cardiovascular diseases. Cardiovascular diseases also account for 45% of deaths in 40 to 69-year age group. Cardiovascular diseases strike Indians a decade earlier than the Western population. Burden of cardiovascular disease became apparent in the national lung screening trial, in which number of deaths due to lung cancer and cardiovascular disease were found to be equal. A high burden of coronary artery calcification may be present in patients classified as low risk by traditional risk factor scoring systems, and conversely can be absent in patients classified at high risk. So combining coronary artery calcification with traditional risk factors can improve coronary artery disease risk stratification and appropriately target statin therapy, which can significantly reduce future coronary events. Now coming to reporting of coronary calcifications. Coronary artery calcification is an established biomarker of the burden of atherosclerosis. It is simply identified as a high attenuation material in the path of coronary artery. As we can see in this image, a high attenuation material in the path of LAD. And estimation of coronary artery calcium requires a dedicated non-contrast ECG-gated cardiac CT, in which calculation is done by Agatston scoring that remains the gold standard for the assessment of coronary calcium. It uses semi-automated software to identify areas of calcification. Any area that is above 130 Hounsfield units is considered as calcium. This table shows the Agatston scoring system. In this column, on the left hand side, we have the score starting from 0 to greater or equal to 300. On the right hand side, we have the risk group from very low risk to high risk. And a score of greater than or equal to 300 Agatston units have 7-fold increased risk of MI or coronary heart disease death compared to those with no coronary artery calcification. In addition to Agatston scoring system, there are other semi-quantitative ordinal scoring systems, but the problem with these scoring systems is that these take time and training to perform, which is not suitable for routine CT chest practice. For routine practice, reporting coronary calcification on non-gated thoracic CT was found to have an excellent diagnostic accuracy compared to gated CT, but the problem was that it was not frequently mentioned in the reports on non-gated CTs performed for other indications. And a recent study from Canada showed that only 17% of non-cardiothoracic radiologists were aware of the correlation between the coronary artery calcium score on gated and non-gated thoracic CT, and there is no upper age limit for reporting of coronary artery calcification. And this consensus statement recommends that a simple visual ordinal score that range from none, mild, moderate to severe should be used, and it can be applied to both non-contrast and contrast enhanced images. This slide shows a set of images from the article which grades coronary calcification from none to severe. On the top row we can see the non-contrast scans, and on the bottom we have the contrast scans. From left to right we can see there is an increasing order of calcification with none represented by figure A to severe represented by figure D. Severity assessment is subjective, but it is very simple and does not require any complex calculations. Application of this simple visual ordinal score in the National Lung Screening Trial identified patients at increased risk of subsequent coronary heart disease related deaths. And the scoring system was found to have a good correlation with Agatston scoring, excellent inter-observer agreement, and acceptability to non-cardiac radiologists. The main purpose of this exercise is to identify patients who are at risk of cardiovascular disease but have not been identified yet. So reporting incidental coronary artery calcification is not required if the presence of coronary artery disease has already been established, if there are signs of a previous coronary intervention, like for example we can see a coronary artery stent or we can see evidence of a coronary artery bypass graft. This slide shows an algorithm for coronary artery calcification. Now the first step is that we have a CT chest, either a contrast or a non-contrast that has been done for some other purpose, and we identify coronary artery calcification. Then the next step is to determine the severity of the coronary artery calcification. So either there can be no coronary artery calcification or there can be a mild, moderate or severe coronary artery calcification that indicate presence of a coronary artery disease. After determining the severity, further course of action is given in the radiology report. If there is no coronary artery calcification, then no further action is advised. If the patient has associated symptoms, then recommended management as per the chest pain guidelines is advised. If the patient is asymptomatic, then we consider reviewing modifiable cardiovascular risk factors and managing as per guidelines for primary prevention. These guidelines also provide action plan for general practitioners and other referrers. So if the patient is asymptomatic, then a review of modifiable cardiovascular risk factors as per guidelines is required. On the other hand, if the patient has symptoms like chest pain and breathlessness, then he is managed as per chest pain guidelines. This is an example of a structured report. So at the end, once a chest CT has been reviewed, which was done for other indications, and in the impression it has been concluded that the patient has normal lung parenchyma, but in this case they have found some moderate coronary artery calcification. Then they mention it in the report in the format that we have earlier alluded to. So the patient, for example, had moderate coronary artery calcification indicating the presence of coronary artery disease. If the patient has associated symptoms, recommend management as per chest pain guidelines. However, if the patient is asymptomatic, consider reviewing modifiable cardiovascular risk factors and managing as per guidelines for primary prevention. As far as aortic valve calcifications are concerned, aortic valve calcification on CT is associated with severity of aortic stenosis as assessed using echocardiography. And cutoff values for aortic valve, Agatston's calcium score has been established to identify patients with severe stenosis. For example, if the patients have greater than 2065 Agatston units for males and greater than 1274 Agatston units for females, they have a severe aortic stenosis. And good thing is that Agatston scoring of aortic valve calcification can be performed on non-gated CT scan as well, with good correlation with echocardiographic parameters. How to report aortic valve calcifications? Like coronary artery calcification, the guidelines recommend that a simple visual ordinal assessment be used, and the score, like coronary artery calcification, range from none, mild, moderate to severe, and this correlates well with former Agatston calcium scoring and with echocardiographic findings. Set of images showing the visual scoring system as we have seen in the coronary artery calcifications. So these are the set of images on the top row. These are the non-contrast images showing the increasing order of the calcifications from none, mild to moderate and severe. So middle and bottom we have contrast enhanced and multiplanar reformatted images showing the severity of the calcium deposition in the aortic valve from none, mild, moderate and severe. There is an algorithm for cardiac valve calcification as well. So first, again, we have a CT chest, contrast or non-contrast. We have identified cardiac valve calcification. The next step will be to determine the severity. So we can have no calcifications for aortic valve. We can have aortic valve calcification, or we can have mitral valve or mitral annular calcifications. Once we have determined the severity, for the cause needs to be mentioned in the radiology report. If there is no calcification, no further action is to be taken. If there are aortic valve calcifications, if these calcifications are moderate or severe, then this may indicate the presence of aortic valve stenosis. Then we have to consider echocardiography if clinically appropriate. In case of mitral valve or annular calcification, so we have to write in the report that there are mitral valve or annular calcifications. Action plan for general practitioners in case of cardiac valve calcifications. In the aortic valve calcification group, if the patient is asymptomatic, then a general practitioner is required to consider echocardiography if not previously performed. If the patient is symptomatic, that is, the patient has a chest pain, breathlessness, or exertional syncope, then echocardiography and referral to cardiology clinic is required. In case of mitral valve calcifications, they are likely of no clinical significance, but this will depend on clinical context. This table provides a reporting recommendation for coronary artery and aortic valve calcifications. So for coronary artery calcification, as we have already seen in that reporting format, once we identify these calcifications, we have to mention either mild, moderate or severe coronary artery calcification is there, and we have to indicate that the presence of coronary artery disease is there, and we have to also mention the next step in the management. And if the patient, depending upon the symptoms of the patient, if the patient is associated with symptoms, we recommend management as per chest pain guidelines. However, if the patient is asymptomatic, we consider reviewing modifiable cardiovascular risk factors and managing as per guidelines for primary prevention. Similarly, for aortic valve calcification, if we find any moderate or severe aortic valve calcification, so we have to write that this may indicate the presence of aortic valve stenosis. Consider echocardiography if clinically appropriate. As far as the calcifications in other parts of heart is concerned, like mitral valve, myocardium and pericardium, so one can identify these on thoracic CT, and their significance will depend on the clinical context. This slide here shows mitral valve calcifications. So in this image, we can see the mitral valve calcifications involving the mitral leaflets, and in image B we can see calcifications as represented by yellow arrows involving the mitral annulus. As far as mitral valve calcifications are concerned, so calcifications of mitral valve or mitral annulus is a common incidental finding occurring on approximately 8% of routine thoracic CTs, and mitral leaflet calcification may be associated with rheumatic heart disease or advanced renal impairment. Patients with mitral valve calcification may require further assessment of mitral valve function, whereas mitral valve annular calcification is rarely a therapeutic target. So like coronary aortic valve calcification, so there is a visual ordinal scoring system for mitral valve calcification as well. From the left to right, we can see an increasing order of severity from none represented by A, mild, moderate and severe, severe represented by D. There can be calcifications in other parts of the cardiovascular system. Here is a set of images showing calcification within the pulmonary arterial wall as represented by yellow arrow in figure A, on the papillary muscle in figure B, and myocardium and interventricular septum. So as far as these myocardial calcifications are concerned, causes can range from infarction, trauma, inflammation to neoplastic infiltration and infections. And significance like mitral valve calcification will depend upon the clinical context and indication of imaging. We can have pericardial calcifications as well, as seen as this benign type of calcification in figure B, and here in figure C we can see myocardial calcification thin along the apex, likely a calcification following an infarction. So pericardial calcification can also be seen on routine non-gated non-gated thoracic CTs, either contrast or non-contrast enhanced, and causes can be numerous from infections, cardiac surgery, radiotherapy, rheumatic heart disease to collagen vascular disease to hemopericardium, and the significance of the pericardial calcification will depend upon the clinical context. So the take-home message is that heart should be reviewed on all CT scans where it is covered on the imaged field of view, and the presence of coronary artery calcification should be identified, quantified using a simple per patient visual quantification score from none to severe. And if coronary artery calcification is identified, simple recommendations regarding further assessment management should be provided in the report text, as we have seen uh, in our previous slides. And similarly for aortic valve calcification, we have to identify aortic valve calcification, then using a simple visual ordinal scoring system we have to provide a severity score from non, mild, moderate to severe. And once we have provided a score, and we then, as an additional finding for the this aortic valve calcification, we also have to mention aortic root and ascending thoracic aorta diameters, and simple recommendations should be provided in the reported text, as we have already seen in the algorithms that have been provided. And also the presence of other calcifications like in mitral valve, like in myocardium and pericardium should be identified and reported. However, no guidelines regarding further managements are issued, and these will depend upon the clinical context and the indication for image. This slide shows a set of images that have been taken from the Department of Radiodiagnosis at All India Institute of Medical Sciences, New Delhi. From left to right, we can see faint calcium along the path of the coronary artery. Then in the middle image, this calcium is becoming more dense, and on the extreme right, we can see a big chunky calcifications. So from left to right, we can see the severity visual ordinal scoring system from mild, moderate, and severe. So another set of images taken from our department. Here on the extreme left, we can see the aortic valve showing calcifications. In the middle, calcifications involving the mitral valve leaflet. And on the extreme right, again the calcification involved the mitral valve leaflet. These calcifications can be, one can visually say that aorta has moderate type of calcification, then mitral valve leaflet in the image in the middle showing severe type of calcifications, and on the extreme right showing a moderate type of calcification. One must realize that this scoring system is entirely subjective. To conclude, this consensus statement provides guidelines that are simple to implement in day-to-day practice in order to identify patients at risk for cardiovascular disease and provide timely intervention in order to reduce the morbidity and mortality associated with cardiovascular disease. Thank you so much. Thank you for your time.